Hello, Athletics Weekly and all the readers and listeners. It's Paul Hobrough here again for Ask The Physio. This is the April edition in 2022. So I've got three great questions, and thank you for the multitude of people that sent questions in. We do our best, but we've got to pick three because it's a short segment. We don't want to be going on for ages and ages. So the first question: what's been one of the most rewarding experiences that you've had in a job where an athlete has made a surprisingly good comeback from injury? There's so many to mention. One of our greatest runners, getting them ready for their last ever marathon all over the TV, and spending a week with them to make sure that happened, and witnessing the end result. There's another person that kind of sticks out, and I'm sure she won't mind me mentioning it, but it's Ali Dixon, who is struggling with an issue with her quad, a leg going dead at about an hour's running, and if she were to lean forwards and offload like the quad for about a minute, then her leg would come back to life and she could get back running. Well, if you imagine over a marathon where she's trying to get picked for the Great Britain team to get the Olympics, if you pause for a minute and you've got to do that twice, then you're going to be overtaken by your competitors. So this wasn't an option. And we looked at a video of her running. It's very fortunate there was a half marathon on the TV the week before. And we looked at all sorts of things, including the curve in the lower back, tension that was putting through the anterior hip, and recognized that there was a loss of blood flow and a loss of neural impulse, the nerve getting through to the quad. So by making some sort of strength adjustments to the lumbar spine to just pull that curve back a little bit so it wasn't quite as severe. Not that there was a weakness, but we needed to adjust the pull front to back, and the problem went away. Of course, she goes off, gets selected. And it's just about being able to put that drop of oil in the right place. And oftentimes you've got athletes that are coming to see that have seen loads and loads of really eminent people. And I'm not saying that means that, you're the one that came up with the answer, but sometimes you get a chance to sift through because other people have done the hard yards, and you get a chance to step back and go, well, if it's not all these obvious things, what could it be? And again, someone who is very great success was Mazzacoro, and we actually ended up doing a whole load of MRI images around a suspected hamstring injury and realized it was more to do with a piriformis muscle or lack of, and that then gave way to me actually having to go into my garage and figuring out exercises that could work on other muscles to maybe take over. It wasn't the hamstring after all. It was something else. But again, the people that have gone before searching and not finding the answer allows you sometimes just to take a step back and find that drop of oil that goes in the right place that makes the difference. And so lots and lots of rewarding things for me. I think the key to each of those elements of working with these top level athletes is that when you're working with someone at their top level, so imagine a car mechanic working on a Ferrari F1 car, it's actually very difficult to find fault because everything is working so well. So when you do find a fault, which is like splitting a split hair or the veritable needle in a haystack, that gives you the opportunity to then start to look at your other patients that come in through a different lens, through a different scope, and enables you, I think, to have a much more analytic brain to look for dysfunction where perhaps your standard physiotherapy tests, strength tests, hop tests, all these sort of things are not showing up as giving you the right result that you might be thinking of. So it just gives you scope to work with the masses when you've had to work so incredibly hard over sometimes weeks and months to find the diagnosis. And once you have the diagnosis, it then becomes fairly easy to resolve the problem. The diagnosis is key, and getting that right is always worth spending time to do that. And my time working with elite athletes has only served to create great benefit when I'm working with other people. So I like that question. Thank you. Question 2, what's the solution to getting rid of knee pains and hamstring injuries? So I'm going to attack these two separately. I wonder if this particular reader is talking about having a knee pain with a hamstring injury, because that would not be uncommon. And just to quantify that, when you have some sort of insufficiency with your knee, it is quite normal that one of the hamstrings or the hamstring group would start to overwork to try and help control that injured knee. So therefore you have a knee problem and end up with a hamstring injury, or your hamstring is causing you problems, so you load the knee differently. But I think I'll take this as two separate ones. So knee pain, 20% of all of the injuries that runners have tend to be with the knee. It's just a statistic that shows that knee is probably the greatest prevalence of injury that runners are plagued with. So we know quite a lot about it. Even people refer to it as runner's knee. Now, runner's knee tends to be coming from the IT band down the side of the knee here. And what we believe to be happening is friction being caused at the outside of the knee. As the knee wants to drift in towards the midline, the IT band tightens up to try and keep it in a nice straight line, and that tightens up and gets friction. So the IT band has a tensile strength of steel. You will get bored of me saying this. I think I say it every single episode. I've said it in my books. I've said it in most of my columns for Athletics Weekly. The IT band has a tensile strength of steel. You are not going to lengthen it. However, a little muscle just up here called the TFL, which is a contractile component, one of the contractile components of the IT band, you can work with. And actually getting a golf ball, so laying on your front, getting a golf ball into your TFL. And if you want to know its better location, the little pocket looks like it's a coin pocket, I think, on your jeans. Just underneath there is where the TFL is. So you kind of lay on your front, you get the golf ball between that muscle and the ground, and you find a particularly tender spot. What we're doing with trigger pointing is to try and reduce down the blood flow to that muscle momentarily, because without blood flow, the muscle can't stay in contraction, and these are trigger points. I'm conscious that I know the third question is about trigger points, so I might be spanning these two together. And by starving that trigger point of oxygen, because you've starved it of blood, it gives you a window of opportunity just to stretch those fibers out, and that will give, excuse me, a little bit of extra give, shall we say, to the rest of the IT band. Not because you've lengthened the IT band, but it's like a little bit of elastic at the top. You just a little bit more give in it, and that can reduce down the friction momentarily. What you then need to work on is strengthening up through that whole unit. So things like single leg squats, double leg squats, lunges, making sure that your glutes are firing by doing, imagine this is my knee and my hip, and you're doing the Cram exercise or straightforward abduction exercises. Glute strengthening exercises are paramount, and all of that leads to a much more controlled forwards hop, sideways hop, backwards hop, which builds up the strength and the kinetic chain through that whole area, and that will support your knee. But for a short term, you can just work on that TFL. If your knee is a bigger problem and you're getting into things like osteoarthritis, or you've got cartilage problems, it's different but the same. You still need strength, and squats and lunges, if you're capable of doing them through not being too painful, are going to be your friend. And whilst I don't really like machine weights, I think as an adjunct, if you're doing those free weight exercises, you can also gain some benefit from doing, the leg extension and leg curl machines in the gym, where you're able to load that muscle up, but not those on their own. They're not functional. You need to be spending time on things like squats and lunges and deadlifts and stuff like that. Hamstring injuries. So we don't tend to see lots of hamstring injuries in more of the distance runners. Sprinters, where you're asking for a much more maximal contraction, you're more likely to pull up with a hamstring problem. Hamstrings become tight for a whole host of reasons. And what you need to look at is not necessarily that I have tight hamstrings, it's what else is going on. So do we have some tension around the pelvis? Do we have a weak core, which means that we're hanging off our hip flexors, which means that we're changing the way in which our glutes are activating, which means we're changing the stresses on our hamstrings? Is it our running style? Is it our footwear? Is it all sorts of things? But you will gain an awful lot by starting to think about strengthening these areas up. So yes, the message coming through is strengthen, strengthen, strengthen. I don't think that there's anybody alive that would feel that by doing some strength conditioning training around your running training is not going to A, give you free speed, make you a better but more resilient runner. So if you're not in an injured state, then definitely strength training. And interestingly, there's much more evidence to support a gain in strength than there is to suggest that you can get massive gains in flexibility. But still, if it's tight, do some stretch work on it. You'll never find someone that does 6 months of yoga and complains that they're not as flexible. So you're always going to get a benefit from these sorts of things. And it's super important that you work on strength and flexibility together. So there is this thing called the Nordic hamstring curl, which we get a lot of our elite football players to do, which is where you're kneeling, like if you're accepting communion in church, or I can't think of another way, kneeling tall, and someone locks onto your ankles, and you, with straight hips and shoulders, you lean forwards, the hamstring's loaded, and you come back again, and you repeat that. So quite a high-end exercise, as is perhaps doing deadlifts. So you want to start working on some lower level stuff, like laying on your back, putting your heels on a Swiss ball, lifting your hips up into a bridge, and just bending your knees and pulling the Swiss ball towards you, going onto a hamstring curl machine, doing some slightly knee bent deadlift type exercise. And you can start to build up your hamstrings gradually, and then build up to things like the Nordic hamstring curl, which is a very high-end level. I'm sure you'll see this in one of my columns I've done for Athletics Weekly. It's certainly in Running Free of Injuries and the Runner's Expert Guide to Stretching, which isn't actually a book just about stretching. There's more strength work in than there is stretching, but you know, that's a discussion I had with the publisher at the time. So hopefully that helps. Moving on. Oh, just by the way, on the hamstring injuries and osteoarthritic knees, everyone knows I'm a huge advocate of shockwave therapy, and I have used shockwave a lot on osteoarthritic joints. If you can get the focus shockwave, true shockwave, not the radial pressure wave, the jackhammer one, doesn't really do anything for bone. But if you can find someone that's invested in a much, much more expensive, much more powerful focus shockwave device, that will do wonders in helping reduce pain in your osteoarthritic joints. And also for high hamstring tendinopathy, any tendinopathy, it works really, really well at accelerating the speed at which you improve. And that's got some really good emerging science to support its use. And I can tell you anecdotally, it is fantastic. So question 3, is there any evidence that muscle knots / trigger points exist, and can tendon injuries cause muscle tightness in the affected associated muscles? Let me do the last one first. So, let's go from front to back. So this is one of those subjects which has become interesting, because there are people that don't believe that muscle knots and trigger points exist, which is interesting, because what are you feeling when you know, the classic ones are in your shoulders here. So if we don't want to call it a muscle knot or a trigger point, are we calling it, I don't know, an overlap of muscle fibers? There's a lot of evidence and a lot of discussion around this, but my belief is that they do exist. I think that it's difficult to talk about them not existing. I think what people are interested in is what's the clinical relevance of them. Now, let's go to the last part of that question, which can tendon injuries cause muscle tightness in the affected associated muscles? So there is a really lovely study, again on Shockwave, where they were looking at plantar fasciitis, that pain on the underside of your heel, and they did shockwave therapy just on the site of injury, on the underside of the heel. And there's a separate group where they did trigger point work. So they found the trigger points in the calf muscle and they shockwave those and shockwave the underside of the foot and got better results. This has then been extrapolated out. They've done more science to look at when treating the trigger points in the associated muscle, as well as, say, for Achilles tendon, so working on the calf again, or for the plantar fasciitis, they actually got a much better outcome. So that helps me to understand the benefit of working on trigger points, is that they actually had a really positive response on an injury. So I would say on the basis of that science, yes, you can get muscle tightness and you can get trigger points, and working on those is actually very beneficial for the latter outcome. So I believe that muscle knots or trigger points exist. I think it's fairly interchangeable wording. And I think working on them is really very, very useful. And this is one of the things I have where people say that massage doesn't work, because if you were to go to a spa and have a nice gentle rub, you might feel wonderful and there might be stress relieving elements to that. But that is very, very different to somebody working hard on your trigger point in an attempt to release it. Like we were talking about earlier with the TFL, if you can get some pressure into that muscle and reduce the blood flow, and therefore you reduce all of the nutrients needed to keep that muscle in some form of contraction, and then you stretch it, key, afterwards, can you get a bit more displacement of those muscle fibers in the cell, and therefore create a bit of extra length? The results are equivocal, but the anecdotal evidence would be suggestive that patients feel a lot better. My patients certainly seem to benefit from it. And when I use it, they seem to get better quicker from their injuries than when I don't. So there's got to be this thing that science must lead us and guide us. I don't think that it's helpful when people are only zoned in and live or die by one scientific paper. I think you've got to take a broad spectrum overview and see what works in practice. So I like to think of these three interconnecting circles. We've got the science and what that tells us, and that guides us, definitely guides us, but shouldn't blind us. We've then got all of the experience and the anecdotal stuff that we know as practitioners and we've seen work, and stuff that we've seen that hasn't worked, and for us or for various different patients, and we've got to keep an open mind about that. And then we've got the patient, what the patient wants, what they know has worked for them in the past and what their beliefs are. And in the middle, we've got the tiniest little section that interweaves with all of that. And that is often the most productive route to start with your patient. And if you get a result using the intersection of those three, then that's great. Patient's happy, physio's happy, the science is happy. So when you get a disconnect where people have huge erroneous thoughts that isn't in relation to anything the science says and doesn't sit well with anything that you've seen to work or believe, that's when we've got this big education piece to try and get each other onto the same page. But treatment should always be done with concordance. That means that the patient understands what's going on, because it's been well described. It's not just what the physio wants to do, and it's a combination of those two, and you decide on the way forwards. And if there is an understanding of trigger points and the benefits, and the patient likes that, and we've got some science to support it, then that's the route we go. So I don't know if that was helpful to answer that question. It leaves a lot of unanswered stuff, but we could talk for the next hour about that and talk about sort of seminal studies that prove and disprove that. But I'm here talking specifically to, I believe they exist and I see benefit. So I've got to go with that. And if the patient wants that, I think there's sufficient science to support it and we get a great outcome. So listen, 3 great questions. I'm looking forward to the ones next month in May, because I turn 50 in May. So it's a big month for me. And I hope that we get some great questions and we'll celebrate my birthday and the month of May and the season getting going in style. So thank you, enjoy your April, and I look forward to your questions next month.